So I took a slight detour on this, and I will bring it back to entry points, but I think we have to talk a little bit about and build further on what Professor Bonnier spoke about earlier today, and Dr. McBride as well in her talk about how do we start to assess skill, and then it becomes directly relevant to transitions. I have no financial disclosures. I will confess that I am leading the EPA initiative for both the American Board of Surgery and for the Fellowship Council, and I definitely drink the Kool-Aid on this and really think that EPAs are going to be a solution for us in competency-based surgical training that we've really been in search of for some time now, and sort of move us beyond the conceptual idea of it and into reality. So the problem that we're all here and understand and are trying to solve is that we've been really dissatisfied with not the product that we see, but really probably the variability in the product that we see, whether that's at the completion of general surgery training, upon entry to fellowship, which is relevant for this group. It's changing the font for some reason. And I think the other piece for us around competency-based education that's been a problem is that while we all agree with the idea and the concept and the construct of competency-based education, the way that it's sort of rolled out so far has been very artificial and difficult to connect with. So we sort of initially just rewrote all of our evaluation tools to be in the framework of the competencies. We just rewrote the same evaluation tool to say systems-based practice, patient care, medical knowledge, et cetera. It didn't really change in any way how we were doing our training. And along with this, we've really, I think, as Dr. McBride really nicely pointed out, we've had sort of fixed curricula, but we haven't had really a transparent way in which we've moved people forward to autonomy. And we've had really a fixed curriculum and a variable output rather than having a fixed output. So EPAs, again, just to provide more background about this, because what I have discovered is that we often describe EPAs in different ways, and I think there's a lot of excitement around this, but a lot of times we're using the terminology variably. So as has been pointed out, an EPA really is a discrete component of surgical care, I think, and really importantly that assessors can relate to. As I mentioned, one of the struggles with competencies have been that we're looking at things in these very microscopic way, which is not the way we take care of patients. And for most of our faculty, our boots on the ground faculty, if you were to ask them, how is this resident doing with systems-based practice, they're like, I have no idea, I like Joe, so 5. And I think that's what we get, and I'll confess I've done that as well. So versus if you ask me as a pancreatic surgeon, can Joe take care of a patient with pancreatic cancer, I can immediately say, well, I trust Joe to do the preoperative evaluation. He has good judgment as to who needs an operation and who doesn't. He can't do the operation yet. He can manage postoperative complications. It's relatable to me. It's what I do every day. It's the entirety of taking care of the patient. And it touches multiple competencies and multiple milestones, but I don't think about it like that. I think about it as taking care of a patient with pancreatic cancer. So it's much more relatable to our assessors. And I think importantly, it starts with the end in mind. So getting back to this idea that we need to define the end product, how can we be certain that every fellow that we finish is competent to do whatever skills or EPAs we define? And then it's easier to work backwards. What we've done, which I think Corey really outlined nicely in her talk, historically has been the opposite of that. We start with all of the little bullet points, and then we expect them to look a certain way in the end, but we kind of did it backwards. And so what do we expect every entering, if you will, GI surgery fellow to be able to do independently, and then what do we expect every exiting GI surgery fellow to be able to do independently? That's where we start, and then we work backwards from there. And so importantly, EPAs really define the work that we do. It's workplace assessment, and it's based upon the work that we do. So it's rolling up rather than slicing up. And so if we think about this as a way to move forward, it really is an assessment framework. And one of the big points of confusion is that, okay, when we did the competencies and milestones, now you want us to throw that out and do EPAs. And that's not at all what we're talking about. Competencies and the milestones map to the EPAs. All an EPA does is give us a framework where we can actually package the competencies and the milestones in a way that really actually makes sense for once, rather than asking people to assess them in isolation. So it's not throwing out everything that everyone's been working on, but rather it's wrapping it up in an assessment framework that is more relatable for us. It also lends the possibility of serial credentialing. Again, if we evaluate people in isolation in the competencies in these very narrow areas, that's not how you get credentialed for taking care of patients, right? You get credentialed to take care of patients with diseases and conditions, and yes, to do specific types of procedures. And so this really starts to provide a framework both within residency and fellowship that we could envision where you could have serial credentialing. And this is really within the context of general surgery, as we talk about this at the board, this is an area of great excitement, because where we would like to get is to have a transparent way to be able to go to the credentialing committee and say, Sarah's ready to manage a patient with symptomatic gallstones. We've entrusted her to do this across multiple contexts, multiple situations, so we feel she's safe. We'll be available if she needs help, but she should be credentialed to do this procedure. And as we move forward into the future, both with respect to having an educational framework which supports graduated responsibility while still in the safety net of training and your faculty, it also creates a framework where we could envision a future state to pay for GME as well if we lose our current structure. And I think really importantly, this is kind of the ultimate flipped classroom, and the feedback that we get from trainees who are in these models of EPA assessment are for the first time, you all are telling me what you wanted me to do and what I'm expected to do to be entrusted. And that's getting a little further down the road because it relates to how you implement EPAs and how you assess using EPAs. But it's actually true. We've sort of given them a curriculum to say you need to take care of a patient, you need to know how to manage symptomatic gallstones. But we never actually really told them what that looks like. We kind of expect them to guess, we expect them to pick it up. As Raul said, some do, some don't. But using EPAs, we define what it looks like to be pre-entrustable, to be entrusted only with direct supervision, or to be entrusted to do this independently. And so we tell them what they need to know, and they either show up and demonstrate it or they don't. And it's right there in black and white, and it's not that, you know, Dr. Rosenthal is really mean and he won't entrust me, and Dr. Minter is really easy and she said yes. It's did you do it or did you not, and in a really qualitative and descriptive way. So the trainees who have really loved this, and it's also helped them to drive the faculty development, because they'll say, you know, you can't say I'm a 4, that I'm ready for independence. I'm an intern, I can't do what it says here. And so the trainees start to actually develop the faculty as well. So really this is the concept of shifting from a fixed time variable outcome, meaning variable product that we produce because they did their cases, they did their time, to having a fixed outcome and potentially variable time, or a fixed outcome and variable curriculum. So again, we start with the end in mind, and then how you get to that end might look different in different training programs. We all have different strengths in our programs, we have different structures, we have different opportunities, but if at the end of the day everybody can still take care of that patient with pancreatic cancer, or if they're an HPV fellow, I don't really care how you got them there. I know that they're competent to do the thing that we've defined as being important. So just to emphasize this, and I'll move through quickly so we can get to discussion, I think right now, you know, the challenges in competencies are not the lens through which we see our learners. We see our learners through an amalgamation of competencies and milestones. And the measurable component, the thing that we've measured in competencies so far, has been very granular, too narrow. It's as I described, can this resident do systems-based practice? In good doctoring, and what we see as faculty and what our faculty relate to, is really the integration of all those competencies and milestones. Or if you think about it this way, we've asked people to evaluate and assess in these little bitty pieces of what we do as a single unit. It's describing the elephant in all of its little pieces, and people see it through this very narrow lens and don't see the whole elephant. So the whole elephant would be, you know, can they take care of the patient with this disease or condition you care about, not can they do the pancreatic or jejunal anastomosis. So EPAs, again, wrap all of this up together. Competencies focus on a single ability within an entire activity versus an EPA which integrates. And I think also really importantly, from a practical standpoint, we have to be able to do workplace assessment. Whether somebody can do something in the simulation center is very different than whether they can do it in the context of taking care of patients. And as it's been discussed, I think, by Professor Bonnier just a moment ago, there are lots of different conditions and contexts in which we interact with different patients with the same disease or condition. And so we need the opportunity to assess them across all of those contexts and conditions to start to get to that picture that Corey was showing you where you have all those holes punched out. It's not just sort of one and done on a particularly easy case. So again, just to highlight the distinctions between competencies and EPAs, an EPA really is going to address the integration of competencies. It's going to assess this in the workplace. It's really focused on the activity, the entire activity that we do, not a single piece of it. So competencies and milestones are very granular, very telephoto, and EPAs really are looking at the entire big picture, again, across multiple conditions and contexts. And I think that's really important because if you think about it, and we start to weave in the concept of trust, which I think is one of the things that's most attractive to me about EPAs, is the concept of when you change the discussion to talk about trust, I think that you think about it a little bit differently. Do you trust this resident to do this thing to your family member, to you? That's a bigger question than do you think they're good on systems-based practice. It really shifts the dynamic of that assessment and that interaction. And importantly, we have to also be able to ultimately see enough different viewpoints of that resident across enough different conditions and contexts to say, you know what, I trust this resident knows enough to call for help if they get in trouble. Just like when you're a junior faculty member, you haven't seen it all. And while you might be able to do most Whipples, you're not ready necessarily to do the portal vein resection, or if you get into bleeding, you call for help. And so you have enough of a panorama to say, you know what, I think they're ready, and I trust that they'll call for help. And so that's what EPAs start to do for us. So they make sense to us. They make assessment more practical because it occurs in the workplace. It occurs as you're taking care of patients. It adds meaning by integrating the competencies, and it adds trust to the discussion. It really aligns the assessment with what we do on a day-to-day basis, and it aligns education across the continuum. And I think this is one of the things the Fellowship Council that we really have been thinking about is how do we move from residency in terms of having a set of expectations for our incoming fellows, and then we carry it forward from there, as Corey talked about. So for the American Board of Surgery, we are participating in this right now. It is an invitation, not a mandate. This will be an iterative process. There's multiple stakeholders participating in this. The American Board of Surgery is just hosting it, honestly. Myself and Bob Englander from Pediatrics, who led the core EPA work for the AAMC, are leading the group. And to get away from the political bomb of defining what is or isn't general surgery, we ultimately decided to just start with 5 that we could all agree on. And this is just to give you an example of what an EPA is. And you'll note that it describes a disease or condition as the patient would present. It's not about a procedure. So again, this is a lumping, not a splitting exercise. And so the goal here is to develop an assessment framework that will allow for trust to be granted to complete the core activities of general surgeon. We're starting with 5. Within the Fellowship Council work, we're going to be focused on, obviously, the core activities of a GI surgeon, again, across multiple contexts and conditions. And again, it requires your belief that they will call for help if they need help. So you wouldn't entrust somebody who you actually don't think would call for help. They could be fantastic. But if they are cavalier and they won't call you, then you can't entrust them. So these 2 conditions really are critical for entrustment. Importantly, entrustment and EPAs require direct observation. So as Matt Ritter and Corey McBride and I met earlier today, who are leading the Fellowship Council work, we talked about that there are some things that you can start to think about that are really critical to GI surgical care, but that we don't see very often, so maybe we shouldn't make them an EPA. And that's actually not the right answer. The right answer is if we think it's critical to them being competent, it has to be an EPA. And then we have to figure out how to create the opportunity to assess it. If it's something that just never happens, then it can't be an EPA because you won't have the opportunity to observe it for every fellow sufficiently to get to the point of entrustment. So it requires direct observation to make entrustment decisions. And again, trust is this concept of acceptable uncertainty. You trust this individual from what you've seen that in other similar contexts will be safe and would be somebody who you would trust to care for your loved one. So just briefly what an EPA is not, it's not a narrow slice of surgical care, and this is where I see a lot of confusion. It's not doing a procedure, it's lumping, it's taking care of the critically ill patient, of which placing a central line would be a skill that you would assess within that EPA. It does not culminate in one big final exam, and this has been a big learning point for myself, working with Ali Tankade, who's a friend and colleague who advises us on our grant and work in this area, and who's really a thought leader in EPAs. And this is important, and the best way this was explained to me was that you've observed them across multiple contexts and conditions, and everyone has said they are entrusted to supervise others. Then you have one big final test where you give them an exam in one specific patient with one particular assessor who perhaps is a hawk, and who says, nope, they're not ready because they didn't do it exactly the way I wanted them to do it. And the reality is, are you going to allow that to trump the 50 other observations you had where they said they were ready? And so it's not about having a final test at the end of this, it's really about the accumulation of trust decisions that you've put together. EPAs aren't assessed with checklists, they really are assessed iteratively in the workplace. And this will be a point that we'll be spending a lot of time with in the board and for the Fellowship Council. So it's an assessment framework which drives a curriculum, again, looking at the whole activity. Back to the competencies and the milestones, for your faculty, it's really looking at the whole car. You know, can this resident take care of a patient with metabolic disease? Under the hood are all the competencies and milestones that map to that EPA, and only your program director or your clinical competency committee have to know about that. But to the faculty member assessing them, they're looking at the whole car. They don't have to get under the hood of the competencies and the milestones. And so it's these iterative ad hoc decisions that we're making, these trust decisions that culminate with your clinical competency committee or your fellowship director and faculty group, whoever makes that final sort of summative entrustment decision that says they're ready. And that summative entrustment decision is not the same as a summative high-stakes assessment. It's a summative trust decision that is based on lots of data points, including all of these ad hoc assessments that you've done, and whatever other thresholds you've set. Maybe it is a minimum case volume, maybe it is a simulation center experience that were thresholds, but you put all of that data together. And so it sort of looks like this, and Professor Bonnier talked about this morning. For the sake of time, I'll move through this quickly, but we have taken a slightly different approach so far in the US to how we do the assessment. And what we've done is actually brilliant in its simplicity, because it essentially takes, once you have your EPAs, it defines for each of those levels what the learner looks like. So if you manage a patient with symptomatic gallstone disease, you'll have a description that's very qualitative for observation only, direct supervision, so forth and so on. And then the evaluator says, okay, I think you're direct observation because you did this, this, and this. And they dictate a couple sentences and say why they put them in that spot. It tells the resident or the fellow exactly what they need to look like to get to proficient, to get to supervise others, and it's black and white. And it creates this scatter plot of data that over time tells a really nice story. The summative entrustment decision then puts all of that together, and for residency, that's a CCC, and for fellowships, it'll be whatever group is responsible for that assessment, or that summative decision. It's, again, not the same as a big final exam. So if you took this as just made-up data and an example, you can start to see initially there's a lot of variability. You start to see less variability over time, and you see the curve moving up towards supervise others. So just to close, within the Fellowship Council, back to my original charge, this is group work that Matt Hodder and Rory Pryor have really led in trying to think about how do we start to define the EPAs within the different domains of general surgery. And the genesis of this work really has been 2 years ago within the Fellowship Council. We realized in the Accreditation Committee that we had EPAs, if you will, or skills, clinical skills that were occurring in multiple of our fellowship types that were being defined in different ways by different curricula, and we were not necessarily holding our programs to be responsible for producing a consistent product, because we were defining it differently, quite frankly, and it put the Accreditation Committee in a really awkward position. And so fortunately, all of our member societies have been willing to come together to partner to say, let's all get together. We all have expertise in these various areas, and let's work together and define what are the EPAs for HPB, for foregut, for bariatrics. And so all of our societies were asked to decide which groups they wanted to comment on and to participate in, and we're now moving forward with that work. And just to briefly explain this idea and this concept, which we're excited about, is that the blue would be what we would expect an incoming graduating general surgery resident to bring to bear, that they would have some EPAs they would achieve in the foregut area and HPB, et cetera. The striped area would be what a more broad advanced GI fellowship might look like, and then the white space would be someone who focused much more narrowly in a very specific area of GI surgery. But if you did, let's say, one of the bariatric EPAs, it would look the same whether you were in an advanced GI MIS fellowship or a bariatric fellowship or an advanced GI fellowship. The EPA is the same. And so this is the work we're moving forward with. We're excited because it aligns very nice with what's happening in general surgery. And we actually think we plan to develop all the EPAs for the entire triangle, and we'll then, because we're doing the same way, be able to pass those back to general surgery for the blue piece. So where we are right now, and just in closing, is that our societies have all bought into this, which we're very excited about. We're all going to be working together. Corey McBride and Matt Ritter will be co-leading this effort. We'll be developing these EPAs. Really importantly, this is a floor, not a ceiling. I think Corey made this point, but I think it cannot be emphasized enough. You actually have a relatively small number of EPAs for your discipline. This is what every single graduating fellow has to be competent to do, no matter where they trained. It doesn't mean they won't do a lot of other things, but this is where we set the floor. This is what we promise patients. And so moving forward then, we'll be meeting in June to start to develop those lists, and then we'll take that forward to the broader community for buy-in, and then we'll move on into developing the EPAs. So I want to save a little bit of time for questions, so I will close.